I'm Ben Cushing, Chief Architect, Health and Life Sciences at Red Hat.
I'm Dr. Brian Jones. I'm a practicing physician informaticist, which what that means is I sit at the intersection between the delivery of healthcare, technology, and the business of healthcare, making sure we improve outcomes with an economically sustainable model.
And it's also worth noting, Brian actually cares for patients at the VA. He's doing the work on top of building these kinds of systems with
as a volunteer, not an official VA employee. Just to be clear. Yeah.
All right. So, anyways, this was a $20 million grand challenge that the VA put out to reduce veteran suicide. The U.S. Veteran Affairs loses about 22 veterans a day to suicide. So obviously a really, really big problem here within the United States, but honestly, this is probably more of a global issue than you might think. All really stemming from PTSD and a number of other, issues we'll touch on. We got involved in this as into the competition, specifically to try to bring technology forward that the VA had not considered yet for tackling this issue. And we found ourselves in a winning position for it. So we've been very, very excited to be a part of that. We're technically in a phase 3 now, which has been sort of evolving. Before we get into all this, I want everyone to know that this is really an AI talk at the core. That's really what we're doing here. And that being said, Brian, I want to quickly ask you, what are the actual ethical implications of bringing AI into tackling something like suicide ideation?
So we had a hard act to follow kind of coming out here. So our journey through time and space really started on paper. Through all of our lifetimes, really in this room, your doctor's office probably had a manila folder that contained your electronic record in there. So all of your care documentation, we've moved in our lifetimes to the electronic health record. Now, with Ben said, there's 22 to 25 veterans that die by suicide every single day. And 50% of those veterans are not even getting cared for in the VA system. So the challenge that we had was really thinking through how do we move beyond data that's in the electronic health record system and start to bring in data from the community. If you think about data that's in the EHR right now, that's less than 1% of the time we spend living our lives. But to really truly end an epidemic like suicide, you need to start to be able to bring in and ingest and architect different data sources and start to provide decision support on top of that in the form of AI. And that's just the journey we've been down through with our mission Daybreak.
So why don't you tell us about the team we built?
So the end of the day, as we talk about AI, it really comes down to trust. We can make a very slick technical solution, but if doctors, nurses, psychologists, therapists aren't going to use this in the exam room, we've wasted our time. So we put together a multidisciplinary team, which includes the awesome team from Red Hat, Ben and team. Guidehouse, who's really understanding the culture of VA, does a lot of work throughout VA, plus academia. So really the top scientists in mental health are really coming together to really architect a solution that the clinicians on the front line will trust going forward. So the net of all of our work is really creating a capability that is trusted not just by the clinicians that are using this, but also by the veterans that are receiving care.
And I do want to say that we actually completed our build in 5 weeks. So we actually put this whole thing together in 5 weeks, including training the models. And we were able to accomplish that because we just pulled from pretty much every single Red Hat managed service that was out there and put them all together at once. So we didn't have to build everything all at once. It was all constructed and able to work with immediately. So we got into the science as fast as possible, and a lot of the infrastructure was already provided for us. If you have a project like that where you need to get going really fast, that is a method to get going. It may not fit your long-term vision for the infrastructure, but it's certainly a good way to get started. All right, so here's our team. A number of the people are here within the room, and it's actually an even larger group than this here. As you can see, it's cross-section between Guidehouse and Red Hat, as well as Dr. Held, who's a big part of bringing the clinical knowledge and behavioral science into this. All right, for the actual problem itself, I want to emphasize there's already a system at VA for finding veterans that have potential suicide ideation, but the issue to coming back to what Dr. Jones just said is that the data that supports the veterans' suicide ideation is really quite scattered. So it's not just within the electronic health system, it's in the community data as well. So think like data that supports their housing status. You know, the VA doesn't actually have information that tells them about the housing status of that patient, and so they can't use that in the current models they use to produce a score, a risk score for a patient. We were able to transcend that by actually reaching out into data sets that represented the community and bringing those together. Anything else to add here to the problem statement, Brian?
So the problem statement is really an abundance of data statements. So if you've seen a doctor recently, your doctor is probably running behind in their schedule. And they're also overwhelmed with the amount of information that we have captured in the electronic health record right now. So the problem statement, if we're really truly going to solve a problem like suicide that is so complex that requires a look at data outside of the EHR, how do we do that in a way that doesn't become overwhelming to the clinician that may have 30 seconds to a minute to walk into the exam room to review that record before walking in? So how do you start to present that information that's out there in the community and really kind of whittle down what are those data elements that are truly going to change that decision before they walk in the exam room? That's really why that multidisciplinary team was critical in putting the solution together.
All right, so ultimately what we delivered was a system that was really flexible. We were able to pull in all the community data, put it alongside clinical data, and then provide an actual risk score. And that risk score was then able to be delivered directly into the electronic health record. The purpose being we want to reach the clinicians where they are, not require them to change the modality of their workflow or anything like that. So you know, for the different personas we were attacking, the first is we needed to be able to provide a risk score for veterans who are currently using VA for care, veterans who are not using VA for care. We needed to address the needs of the actual VA clinical staff, and then also for the VA non-clinical staff, for the folks who might be working in the community, who might be receiving VA money in community programs for outreach to veterans.
And this is the same data. So we have, there's 350,000 employees throughout VA, and they're all looking at the same data, but what they need is a different look at that data for them to take action based on their job role. So we took personas throughout the organization and actually start to then build based on the look at the same underlying data elements, and that's a key piece to think about.
All right, so just getting to the brass tacks, like these are the kinds of UIs we ended up producing that actually were, you know, being presented to the provider. So this is actually this is a screenshot from the electronic health record showing the actual alert that came up within the record, provided the actual score for the patient's risk for suicide ideation, as well as actual like feedback on why they're scoring so high for suicide ideation, which is quite important. Right now, clinicians don't actually know that if they even get a score, and so they don't even know how to respond or like talk to the patient about the issues that they're facing. In addition to that, we tie that back to the actual parts of the record that were weighted to produce the score. So like things like, you know, which observations were made that were like really made a difference in the actual score itself, so the clinician knows what to dig into. And then lastly, you'll see there's a bunch of phone numbers there, and then social determinants of health data. So the one you probably can't read from back there is, it says food insecurity and substance abuse, meaning that both food insecurity and substance abuse were really heavily weighted social determinants of health that impacted the score. So the clinician has something to talk to the patient about. They can talk about their food insecurity. They can talk about their substance abuse. And then they can also connect them with the team that's listed at the bottom, that's the mental health team that should be working with this patient. So they can follow up, create those follow-ups and referrals to make sure this patient is not just leaving the office to go home. They're actually creating a safety net for that patient as they leave.
When you start to look at, they do these things called psychological autopsies for folks that die by suicide. And what you see in there is a lot of kind of missed opportunities. So as a clinician, you may look at your schedule and say, oh, this person's here for a sore throat, or here for a sprained ankle. But when you dig a little bit deep, if you're not doing that research inside the record, if you don't have capabilities like an AI solution or looking to see what are you missing in there, you may miss that, this person missed their refill of their mental health medications. they've been getting chronic opioid prescriptions. Really, all of those things make them higher risk for suicide, and if you're only going in for a sore throat or a sprained ankle, you may miss an opportunity to have a conversation to simply say, how are you doing today? Or to arrange them to get resources for them to get continued care and opportunities so that you don't lose them in the system.
So this is a view of the community dashboards we were providing for administrators within VA. So the purple there is severe housing issues, and the yellow is food insecurity. And this is all broken down by county. So if you're a VA administrator in charge of investing and divesting programs within different counties, you would look at the distribution of veterans and their suicide risks within those counties to decide where to put money to properly attend to the veteran's needs, entirely outside of the clinical care the patient might be receiving. And in this way, we can actually help the overall environment that they're operating in and thus improve their quality of life at the same time as addressing their more acute clinical needs while they're in the office with the doctor.
It's really providing that real-time information above and beyond really your training as a clinician to leverage those community resources to end this epidemic.
One of the reasons we're able to actually do this across the VA right now as we move into phase 3 is we already have a massive OpenShift platform in use at VA. It's called VA Platform 1. So there's about, I want to say like 16 clusters distributed across the country that are handling a lot of the application load. So we're actually able to take this particular solution and deploy it to just about anywhere to cover all the different regions that VA operates in. There's about like over 2,000 VA clinics across the country that we need to be able to bring this to. So this allows us to do that really quickly and rapidly. Here's a notional architecture of how this all functions. At the center of this, we actually use a FHIR server. So for those who are not in the healthcare industry, FHIR is a canonical data model used inside of healthcare to really help with interoperability. That's, of course, is riding on an OpenShift cluster. We use process automation to do a lot of the sort of like what are the next steps for the patient. And then we're distributing data between the electronic health records, both Vista and Cerner, over CAML. So, whose phone is that?
Is someone calling you, Ben? Is that your phone?
My phone's right here. So we're actually using CAML to talk to these electronic health records and actually structure the data to go into the FHIR server. So anyways, the VA actually has a full-on innovation center where they actually have doing a bunch of AI work now. That's all based on Open Data Hub, which of course is now turned into OpenShift AI. So the VA is like way ahead of this stuff. We actually use the VA Arches as an environment to do a lot of the training and work. And also we train the models on top of synthetic patient data that have been produced by us from the 22 million records that sit inside of the VA's corporate data warehouse. Lastly, if you'll see onto the far right, you'll see that there's coding escalation and modals being produced inside of CPRS, which is the front end that a clinician interacts with. So as you can see, there's a lot of work going on back here on the left side, ultimately going through the electronic health records and then getting it to the clinician's hands without having to train anybody on any new sort of technology. The clinician is unaware of what's going on in the background. This one's more complicated, and you probably definitely can't read any of this. This is the actual data flow for the work itself. So, inbound FHIR messages about the encounter, they're going to a FHIR server. It's ended up going through Kafka and then distributing those messages off the FHIR server back to the actual model serves that we have. And then you can see on the top left corner, that's where the actual training environment is with Jupyter Notebooks. And then we're actually serving those models just below that so they can receive the data. It's inbound through the Kafka broker. All right, so I want to leave you guys with this idea of bias mitigation plus privacy equals trust. So obviously, I just kind of flew right by the technology because we don't have a lot of time. If anyone has questions on the tech side of this, I'm happy to answer those questions. But I think more importantly than how we did it is the implications of what we've done. Okay, I'll start by just saying if I was asking a question of us, the question I would ask is, what is the ethical implications of using an AI for something like suicide ideation, right? What's the risk of getting it wrong and harming a patient? And then my answer back is, what's the harm of doing nothing, right? So there's a really big trade-off here. Do you want to?
And this is an area where somebody mentioned this earlier. The technology has evolved faster than our abilities to really kind of think about it. So when you go to your doctor's office, you probably sign this form that you don't even think about, saying, "Hey, data, privacy, blah blah blah." You probably didn't read the thing. But when you start to think about, just because we can do something, should we do something? So you've signed a waiver for your data inside your EHR to be used by your health system and other partners of their health system. But now as we start to think about ending suicide, bringing in other data elements, should we be thinking about bringing in other types of data other than healthcare data? Do you want your credit score brought in? Do you want your mortgage compliance or you missed paying rent brought in? So these are things that the data, you're gonna think twice about that. You'll think twice about, hey, can all the data on your phone be used from a clinical decision perspective? You're gonna think a little bit longer than you signed that document from a health insurance perspective. So really thinking about how do you create a system as you're coming in and thinking about AI where you as the patient population trust the guidance that your clinical community and trust the data that's coming from. And then conversely, how do we start to think about kind of the laws around data and all the infrastructure behind these capabilities? So these are all areas that there's not a lot of answers for right now, but it's a constant conversation and balance in terms of if we can do it, should we do it, and what are those barriers and guardrails around how we do it. But the net of what we've done in the VA, and the key from an open source perspective is it needs to be transparent. And the fact that this is on the VA environment, in VABO, in a massive OpenShift cluster, really makes this transparent, so it allows the clinicians, it allows the system to have full visibility on that decision, that guidance is being set out. So I think as we start to move into this direction, having that transparency and open source perspective is going to be key to establish trust across all the communities.
I want to give an example. So one of the key markers in all this is the way people behave at 2 in the morning, 3 in the morning. If you're regularly posting on social media at 2 in the morning, 3 in the morning, and you have a regular cadence, then that shows a normal behavior, even though it's sort of out of like a normal hour. As people begin to stop doing that work, as they stop posting social media messages at late hours, it actually represents a retreat from social activity. And the retreat is actually more impactful than what they're actually saying, right? Like, it might be posting about how the quality of their life and everything else, and that's still very important, but the actual frequency in which they're posting is actually an indicator of retreat away from trying to be social with other people, which is an actual indicator. It's a vector towards suicide ideation. So that's the kind of monitoring that we'd really like to be able to do. But to Brian's point, there's a big privacy issue. Are we able and allowed to even capture that kind of information, to provide that kind of insight to the clinical staff that want to, save this person's life?
So how does that data get layered into what's in the EHR for decision support guidance that your clinician will use in the exam room? That's what we're solving for throughout this.
All right, so what's next? We are currently, we actually just over the last 10 months worked within a larger community to build BPMN models that represent the clinical care that's going to need to happen once we discover suicide ideation. So, it's great to just have the risk score and provide it to the clinician, but we really want to orchestrate the care that the patient's being given because we need to standardize it. Most clinicians are not trained on mental health at all, so they're doing their best, but they really don't have a lot of frameworks to follow. So we're actually using BPMN as a means to create a framework to help guide the clinicians. So we've been doing that within the open source community itself. And then lastly, we're really moving towards a deployment and test of this within VA against actual patient populations. So, this is going to take a long time. Like this, you don't get to turn something on like this overnight. But like I said, this journey is going through a number of stages that's going to both harden and validate the approach to make sure that we reduce patient harm and balance that against the reality we live in now, which is doing absolutely nothing.
Thank you.
Thank you.